The two questions that I wanted to ask or address is the importance of ward rounds to junior doctors and what's the importance of junior doctors to ward rounds. Obviously, we all know junior doctors are those peripheral figures who stand at the back, scribbling in a piece of paper, pretending to request tests or something similar. But they're the ones that are still there at the 3, 4 o'clock in the afternoon after the consultant's gone off the clinic. And also, they'll be the face of the rest of the team for the rest of the day. So the importance of the junior doctors really in the ward rounds towards the patient. And I guess we've all talked about it. The end goal is improving patient care. So, and I guess the overall journey. So I wanted to ask a bit of an awkward question, considering what our question is today, which is the ward round dead to junior doctors? Now, why do I ask this quite awkward question? It was actually in the BMJ recently, a Dr. Oliver wrote an opinion piece, and they asked, is the ward round dead to junior doctors? Do we get any input? I know that we saw earlier that obviously us juniors, we run the ward round maybe 3 times a week, but we don't really add. I know a lot of people feel that we don't add very much to these ward rounds. Ward rounds are mostly geared as in sort of the modern demand, patient flow, how can we get patients through, do they need any investigations, can we get it done quickly? And sometimes there is a feel that I'm just an administrative assistant who does the documentation and will then fill out the forms, get a request in, and hopefully that will all happen during the day and avoid it telling off the next day if it doesn't. I think one of the things that's really lacking is the idea of leadership. And I know that leadership is a big thing for junior doctors, particularly coming through now, but I don't think it's actively encouraged as much as it could be. And I think talking back, as we said about communication, one of the sort of most shocking things for me in the sort of a survey of junior doctors is that it's not a tool for communication. A lot of us don't see it as a tool for communication. It's a tool of getting through the work, getting through the jobs, try and make sure that a patient, we've done everything and everything's okay. So I think obviously ward rounds are important. We look at patients, we look at how they're doing, we look at sort of the numbers of blood tests. So the other things that I wanted to address were the other bits of ward round that I think are quite important. I've distilled it into sort of 3 points. The first is junior doctors, as we said, we don't get training. So a lot of what we learn about how to run a ward round is watching our seniors, be it our registrar, our consultant, running a ward round. I remember still as an F1 walking in on my very first day in medicine, being left to my own devices and just sort of going, oh, get on with it, you do the ward round, I'll come catch up with you at lunchtime. Just a bit scary, seeing as I was sort of like second rotation of F1. But it is a case of just sort of learning by rote or learning by modelling what other people think or what other people do. And I think it's sort of learning to sort of be able to take what's good from what some consultants do and what some consultants don't do or do. And I think it's increasingly important because we've lost the apprenticeship model, which I know a lot of people are very protective over because of the way that our working patterns now sort of fit in. One of the other things is when I started working, I had no clue about what was this social services thing that we had to do. In med school, all I did was, we learned about the system, make someone better, they go home. Obviously it's not that simple and we all know that. And the fact that every single hospital I worked in works slightly differently, and I'm coming up to sort of my 4th or 5th one now, and I've only been working here for 5 years, and it's also just trying to adapt every time. Last thing, how can we actually make it better for patients? Junior doctors, as I said, are the face of the team when we're on the ward, so it's an opportunity for us to sort of add at least something to the ward round, and also then to actually be an advocate. I know junior doctors often feel that we're overshadowed and we can't really bring much into the ward round, particularly if it's a consultant-led, or that varies very much on the consultant. So I think overall ward rounds are an educational opportunity, and I think one of the things, particularly in medicine, is looking at what is we can maximise out of a learning opportunity such as the ward round. I think it's recognised clearly, as I've said here, by consultants and juniors, that it is a big learning opportunity. It's a chance to converse, it's a chance to learn about patients, it's a chance to learn about conditions, but it is really opportunistic. And I think one of the ways that we need to think about it is, how can we formalise it a bit more? And also because it will often be determined by what's available on the ward, as in what patients there and how we can learn. But it's also about us seeing how consultants work or don't work. And I think the last thing is, as we said, learning by osmosis because we're standing at the back, sort of scribbling on a piece of paper. I think one of the things that has been written about is about learning on the ward round. And sometimes being able to learn is to sort of have input from both sides. So obviously we want consultants to teach on the ward round, which will make them longer, but it's also about thinking aloud. So consultants thinking aloud will mean that the junior doctors understand where we're going or what will be the next step. And I mean, demonstrations are not only going to show how to sort of examine a patient, but it's also about demonstrating what the thinking pattern is. And you can observe, as I said, and also teaching in small nuggets. So 3 for each case, each patient. And I think it's also very applicable to, say, post-take ward rounds, which I find that I don't really take part much in now, apart from as a junior who turns up in the morning. On a night, if you're presenting all of your patients, you're going to get far more from a post-take ward round than if you're someone who's following along, who's just writing some notes and then doing the job list for the rest of the day. And so, you can follow on, but that's how we are. So I think we should then go on to the system. So what is the system? I mean, yes, the medicine is what I've learned in medical school. It's what you learn, so and so bits of science work. But I think one of the things that I never knew about until I started working was all of these terms. It's quite a lot, and I know we're all probably familiar with them in some way, form, or other. But you work starting as a junior, in every single hospital, everything has a slightly different name, and it's about getting used to that and seeing it work. And it's quite a steep learning curve, at least I find it is. So the second is the system of the ward round. So as Natalie spoke about in the ward round training, the idea of having roles. As an F1 or even as a final year medical student going into ward rounds, you just plopped in, given a ward chart, okay, read off that. And hopefully you know. So it's having that defined roles, knowing that you can speak up. One thing that I think I try and encourage now on my own ward rounds, but it's something that we don't encourage, I feel, in wards. And lastly, I think it's to think about the human factors. So we've got communication in multiple directions. We're talking about, obviously, medical team to patient, but we're also thinking about in-between professionals. So that's, I don't know, the medical team there, between radiology, between surgical specialties if need be, or even within consultant to juniors. So I found multiple ward rounds where you stand there and you go, so what's the plan at the end of it? And it's about being able to sort of stand up and say that. And I think one of the things with juniors is that often we don't feel like we can. So what does the junior doctor actually bring? We talked about how the juniors can't. And as we said, as feet on the ground, we're the ones that will do the requests and talking to other specialties about getting investigations and things like that. But junior doctors are also the face of the team, as I've said. We will speak to patients' relatives, typically in the afternoon when they're coming in for visiting times, and we'll often answer questions. So I've spent long afternoons doing just answering questions. What's the plan? Where are we going? And we also reevaluate patients. There's also the administrative side. I think you've seen filling out paperwork for, checklists for patients to get home, or actually just sort of doing the simple things like, letters in addition to whatever the patient needs. And I think lastly, for juniors and sort of development is about us becoming leaders and consultants in future. With regards to that, it's about being able to lead a good ward round, being able to talk to the patients, without being left with a junior team after sort of trailing after you, not really knowing what's going on, but have filled in a load of computer forms and also written a load of what was probably nonsensical things in the notes. But what can juniors bring to the patient experience? So I've already talked about talking to families. I think I thought this was quite accurate in terms of sometimes what patients can see in a ward round. And I think I agree, it's kind of quite scary when you think of it from the other point of view. And in a really recent sort of study published last year in looking at patients in Sweden, admittedly, they went around and interviewed all these patients after the ward round, and they found that a lot of patients were asking for supplementary information. Not much of what's said on the ward round actually goes through, or they understand all of it. And also it's about after the ward round, junior doctors, we can revisit topics. We have more time than sort of trying to get through all of the other sort of patients and everything else. We can ask questions, they can ask questions, or we can speak to them in private. Although I find that increasingly it's difficult with no rooms available in the ward to speak to them. And I think the last thing is about having an advocate to encourage you to participate, be that the nurse, be that the junior doctor, be that a physiotherapist on a ward round saying, oh, actually they raised this point earlier, and then addressing it again, say on the next day's ward round or in the evening ward round. So why, as we said, we talked about education, we've talked about the working within the system and improving the system, and we've talked about how junior doctors are sort of the face to patients. So just to sort of coming towards the end of really my talk, the importance of ward rounds to junior doctors. We talked about education and training, a lot of which is opportunistic, and we are based sort of slightly hampered in the sense of what comes in to learn scientifically, but obviously every patient's different and their communication and their needs are different. And I think it's a case of, although everybody goes, yeah, we should have a teaching ward round, or the medical sort of trainees will say, or the trainees generally will say, yeah, I want to learn on the ward round. It needs to be driven by both sides. And I find that from both sides, it's not usually that pushed on. It's all about provision of how do we get our next patient through so that we can find a bed. And with regards to junior doctors to ward rounds, the junior doctors are there to help do the extra bits of legwork that the consultant can't do because they've got other sort of commitments. And also, if patients deteriorate, the junior doctor is going to be the first one you see. As we heard, the registrar was the one that came to examine. And we do need to learn, because we're going to be consultants probably in about 5-10 years' time. And we want to be as good as the ones that are there. So although it's great to see that you have consultant contact on a daily basis, as juniors, we're not going to be able to become consultants if we don't see what's good and what's bad. And also learning our sort of support within the ward round, be that from the allied health professionals, and also be that from sort of ourselves and learning how to structure a ward round and make it accessible really for patients and also anybody joining in. And also, lastly, we are there as information givers potentially at the end. So in summary, junior doctors and ward rounds, we're intertwined. There is no way of separating us. But I think as an educational opportunity personally, I think it's one that needs to be explored a bit more. I don't know how. And obviously, as I said, it needs buy-in from both sides, be it the teacher and also the learner. I think it's also the area where we are going to develop, we're going to become consultants in future, we'll be running ward rounds. So I think it is important and it's unpredictable. And that's all I really have to say. Thank you for listening.